Good afternoon, everybody. I think we should get started. It's a real pleasure today to introduce our special visitor and speaker, Dr. Gerald Winakur. Dr. Winakur has been in the geriatric news, if you will, for recently, nationally, for an article he wrote, which many of you have read, I think, through the email or through the hard copy that we have out in the hall. An article that came out in July in what is it?
Health Affairs.
Health Affairs, right. And this was sort of a wake-up call, I think, for the nation. It really hit a nerve. For those who were listening anyway. And so Dr. Winakur was summoned. I'm not sure, to Philadelphia. Is that where Fresh Air is?
Well, fortunately, I didn't have to travel anywhere.
Oh yeah, you were on the phone.
They taped me in Washington.
And then to the Diane Rehm show in Washington. And a number of you may have heard that. But this is not only an informative, but a very moving article. And I think for healthcare providers and us geriatricians in particular, it strikes a nerve both professionally and emotionally, if you will. Dr. Winakur is a practicing internist and geriatrician here in San Antonio and has been so for over 30 years, I believe. He's an associate faculty member at the Center for Medical Humanities and Ethics here at the Health Science Center and lectures in humanities at UTHSCSA. He's contributed any number of essays and poems to many national journals and has been a contributing editor for Medifors, a literary journal for the health professions. He really reminds us of the humanist in the internist, and I think it'll be very interesting for him to share his experience and this article in particular with us. And I don't really know if this is a seminar, if you will, or if this is an interactive session, but I think whatever it is, it'll be very enlightening to all of us. And we really thank him for taking the time away from his daily schedule to come and speak with us today. Thank you very much.
Thank you. I really do appreciate Dr. Katz inviting me here and the opportunity to be with all of you. I feel a little funny. I'm going to have to stand here because I'm going to have to work the projector and change slides as I read. Coming back to the VA is a bit of a homecoming for me because my residency class here at the Health Science Center was the first to staff the VA when it opened in 1973. So, you know, I'm getting up there. I'm not going to look around too hard, but I'm getting up there. But it's good. It's nice to come back. So thanks for having me. I want to applaud the good work you're all doing here. You know, many of my patients over the years, even though I'm an internist and a geriatrician, many times I've needed some help. And and your division has helped me. I particularly wanted to thank Dr. Lichtenstein in this regard, but you're doing great work here, and keep it up. Now that I'm about to complete my first 30 years in practice, I want to say that the most enjoyable aspect of my career has been the long-term, ongoing relationships with my elder patients. It's sad for me now, because there's not a week that goes by that I don't lose someone I've cared for over decades. But I feel that I've made a difference in their lives, and those of you in geriatrics, I know that you know that this is our major reward for the work that we do. Dr. Katz mentioned this, but I just want to take a minute about and talk about the Center for Medical Humanities and Ethics here. So some of you know the work that's being done there. I know some of you have participated, but I just want to put a plug in for the center. I really enjoyed working with the first year and the fourth year students in these ethics modules the last several years. They're a great bunch of students. I think they're getting more idealistic and more compassionate every year. I don't know what you're all doing in the admitting office at the medical school, but I feel like I've noticed a change. They need mentors, they need role models, and I don't know a better place to recruit the kind of doctor worthy of emulation than here in the geriatrics division. So if you can get involved, you've not been involved, and you can get involved in teaching these students in these small group sessions in these modules, I would encourage you to do so. I've been asked to speak about an essay I wrote called What Are We Going to Do with Dad?, which, as Dr. Katz mentioned, appeared in Health Affairs this summer. And the thing got out of my control. I mean, as you know, if you give an article up to a peer-reviewed journal, I mean, they keep the copyright. And the next thing I know, it ended up in the Washington Post, and I literally didn't know anything about it until like the day before. The editor called me and said, by the way, it's going to be in the Washington Post Outlook section. I've excerpted it. Would you like to see what I'm going to put in the paper? But by then there was nothing I could do. I couldn't change it, and I made the grave mistake, although really in some ways it's been a blessing, of leaving my email address on the Washington Post article. But anyway, then what happened is that after it appeared in the Washington Post, it got sent out on their news service, and any newspaper in the country that subscribed to their news service could purchase it from the Washington Post. And then the article appeared in about 20 or 30 papers, Sunday papers, all over the country, and every weekend I would get another flood of emails as a result of this. And as Dr. Katz said, I was on Diane Ream's show and Fresh Air, and I was invited to speak at national gatherings and of healthcare providers, and a magazine asked me to write a monthly column on aging and elder care and write a book, and I mean all these things that I never really expected. I mentioned that I wasn't prepared for the emails and the letters, really literally thousands of them. I, like most of you that are going to go into clinical practice or are in clinical practice, I've just spent my years as a doctor trying to solve problems that are occurring, medical problems, social problems, but that are occurring kind of one at a time, that arise in my patients, in my exam rooms, in my consultation rooms, at bedsides in hospitals or skilled units and nursing homes in which I've been working every day. And suddenly I was getting all these messages, I mean sometimes hundreds of messages a day, pleas for help and advice for an elder parent or an ill spouse, heartbreaking stories of neglect and loneliness, bitter, disappointing encounters with other healthcare professionals, and not just doctors, nightmarish tales of end-of-life suffering, deep expressions of guilt by children living far from home, expiations years after the fact, requests for appointments by elders living in other states, and advice on how to die quickly and painlessly. I brought up my email each day with a feeling of inadequacy and dread. After thinking about all the correspondence I have received and reflecting on my practice career, I've come to a few conclusions. There is an intense, indeed a passionate desire among a huge segment of our populace to have more information about what will happen to them and to their parents as they age. There is an extremely high level of dissatisfaction among many of our fellow citizens about the care they or an elder loved one has or is receiving on a day-to-day basis. And finally, there is fear and frustration and loneliness and a sense of disenfranchisement among our senior citizens and their families. In America today, particularly in the halls of Washington, there is a massive denial of this reality. A vast inland sea of elders will soon overwhelm the weakened levees of our healthcare system. I know I'm preaching to the choir here, and that the information I'm about to show you, which I've adapted from this very excellent publication, by the way, which is free from the government, and here's a way to get something actually free from the federal government. This just was published in October, and those of you that haven't seen it can go online and order it, and I'll send it to you. And there's a lot of good information in there. But I'm building to a bigger point, so please, I know you know all this stuff, but let me go through it. From the graph, and particularly the bottom three trend lines, one quickly notes that the segments of our population which are growing most rapidly are our elderly. Between 1900 and 2030, those over 65 have grown and will grow from 3.1 million, or 4.1% of our populace, to 71.5 million, or almost 20%. Even more stunning are the numbers of the old and the oldest old. The former group will more than double between 2000 and 2050, and the latter will more than quadruple to 18 million people. While this increase in longevity speaks for the stunning success of certain of our medical advances, here is the price we pay. A very significant and growing number of people will suffer years of enfeeblement, disability, and dementia, eventually incapable of caring for their own elementary needs. Here are a few facts in this regard. After age 85, only 1 person in 20 is still fully mobile. 50% of people over 85 will suffer some major cognitive impairment. There are currently 4.5 million Americans with Alzheimer's, and by 2050, there may be as many as 16 million. Medicare, which is 2.4% of our GDP today, is expected to grow to 8.3% in 2050. What about the social costs? Until now, unpaid family caregivers out of love and loyalty have supplied the bulk of long-term care. In 2000, more than a quarter of adult Americans reported that they had provided care for disabled family members during the past year. That's 50 million volunteer caregivers. Spouses make up 24%, daughters 20%, and sons like me get away with only making up 6%. Guys always get away with it, don't we? Mm-hmm. The average length of time of caregiving is 8 years, and 1/3 of respondents said they spent 10 years or more. Every married couple with 2 still living parents may expect to be involved with or even fully responsible for the care of at least 1, and more likely 2 of these 4 parents, who will live out their last 5 to 10 years in an increasingly enfeebled or demented condition, incapable of looking after themselves. And because there is no reversing this, the better they are cared for, the longer they will be in need of more expansive and expensive care. Later in life, and this is what we all have to look forward to, close to half of these caregiving children will themselves be in need of similar long-term care. Here's a sobering fact indeed. By 2020, there will be 1.2 million people over 65 who will have no living children, siblings, or spouse. So these numbers are sobering, even depressing for those of us in this field. But here's some more unsettling information. 2 weeks ago, I was invited to address the National Convention of ASA, which is the American Association for Homes and Services for the Aging. These folks run long-term care institutions of all stripes: assisted living units, nursing homes, CCRCs, rehab facilities, dementia units. They are administrators, nurses, marketeers, therapists, device manufacturers, and retailers. They are in the business of providing the services to our patients that we as geriatricians should have some input into. To my dismay, I found I was the only practicing geriatrician invited, at least on the panels in which I participated. I think I might have even been the only medical doctor there. So think about this a minute. When asked about suggestions for improving quality and long-term care, someone actually got up and touted the use of some kind of disposable diaper with a microchip embedded in the thing that alerts the CNA when the patient wets him or herself. And then there was this guy, Eric Dishman from Intel.
The key and the magic of some of the technologies I'm going to show you today, again, if you're thinking Intel, you're thinking laptop or PC. These are big computers that I'm holding in my hands right now for the kinds of things we want to do. right? I'm going to show you some prototypes. This is called a moat. The magic of these little tiny
In case you missed it, what
computers
Mr. Dishman,
that come in
the Intel Proactive Health Research Director, said was, if we continue to put the doctor and the nurse in the loop every single time, we can't scale. So call me a Philistine. If you know Ray Kurzweil's work, the techie guru and the futurist, he's kinder, he calls me a late adopter. But I think I'm a Philistine, but I just can't see where Eric Dishman is going to help very much with my father, who nowadays has trouble operating a light switch. At the ASA convention, I had been prepared to talk about my work with AMDA, some of you know the American Medical Directors Association, and how they have been instrumental in educating doctors in the long-term care arena, the development of clinical practice guidelines, the CMD certification process, and so forth. But it seemed to me that these ASA folks needed even more basic information than this. So here's what I told them. To achieve quality in long-term care is indeed an interdisciplinary activity. Yet physicians and nurses are, I feel, believe it or not, still central to this process. And by physicians, I mean doctors, internists, and geriatricians like you guys, who are trained to care for the frail elder, the complex medical patient on multiple drugs, doctors trained to look for the few treatable, maybe even reversible causes of dementia, trained to deal with the demented elder with behavioral difficulties and all the other geriatric syndromes recognized today. Doctors, compassionate and ethical ones, who will take the time, however much non-reimbursable time it takes, to talk to patients, their families, to seek input and coordinate with the care team. And I had to point out to them, and they were truly shocked to hear it, one more startling statistic, one more example of our health system in crisis, one of which you are all aware. In 2003, only 2% of physicians in the residency portion of their training programs indicated an interest in geriatric medicine. Currently, there's a deficit of 14,000 of us that's going to grow to 34,000 by 2030. And why is this? Here, from my perspective only, are some of the reasons so few doctors choose geriatrics today. We as a society do not value our elders. Just see who makes it onto the front cover of the AARP magazines each month. There would never be a photo of my father there, I can assure you, though I put him here. Medical education emphasizes technology over touch, procedures over cognitive analysis. To put it bluntly, and what I'm about to say has nothing to do with you folks here at this medical center, but I'm ashamed of how debased the medical profession has become. You are familiar with these scenarios. Academicians rushing patients into untested treatment protocols for their own advancement and glory, fudging their pharmaceutical company-funded research results to keep the grant money flowing, physicians in private practice falling over each other, crassly competing, trying to put into place the next money-making technological gimmick, snipping out polyps, sucking out fat, propping up sags, ironing out wrinkles, burning up spider veins, popping in new lenses and joints, pumping up withered penises, and on and on and on. What the hell is cosmetic gynecology anyway, and how many physicians do we need to train to do eyelid rejuvenation and hair removal? Just look in the yellow pages. It's a sobering experience for someone like me, heavily involved in the primary care of the aged, that I can no longer locate a plastic surgeon willing to bring his skills to bear in helping to heal the decubitus ulcer of bed-bound, Medicaid-funded nursing home patient. I wish it were just the super specialized in my profession who act in this fashion. Many of my internist colleagues no longer see Medicare patients. One of them told me, it just takes so long for them to dress and undress and climb off and on the table, their walkers and their wheelchairs. It just doesn't pay. And what managed care has wrought, and what our profession has allowed to occur on its watch. Doctor-patient relationships reduced to corporate contracts, the forced dissolution of bonds forged over years of clinical encounters, the implementation of perverse bonus systems which reward physicians for not giving care, the substitution of a provider-consumer commodity model in the place of a noble calling. For a brief time, I was involved in the formation of a managed care plan until an argument broke out among the board members over continuing what had been free yearly Hemocult card colon cancer screening by our hospital. A number said this would just obligate more office visits to follow up on positive results and deplete the bonus pool. That was the last meeting I attended. Thus, what I have witnessed during the course of my career is this. my profession, our profession, up and down the line, from the most prestigious medical academies to your corner doc in the box, has in too many arenas abdicated its patient advocacy role, and I'm angry, saddened, disappointed, and heartsick about it. Here's another problem. I know we're not supposed to talk about money in these hallowed halls, so I've deleted the dollar signs, which are in the far right column of each of those. The entire Medicare reimbursement system, and I've watched it evolve for 3 decades now, in my humble opinion, needs to be overhauled. It is an affront to me that a doctor who cleans the wax out of my 85-year-old patient's ears gets paid more than I do when I sit down beside this same patient when she comes in complaining of having had a little spell. I have juxtaposed some of these CPT codes not for comic relief, I assure you, but to highlight the incredible reimbursement disparity between technical and cognitive services. Note that I have used the codes for the most comprehensive cognitive services, those on the left. Those are all comprehensive codes. So if you use them too much, Medicare will send you to jail for fraud and abuse. But routine visit codes are about 50% of those amounts. Those are the comprehensive numbers. I just want to mention in passing that many of these highly reimbursed technical services, fluorescein angiography, which is $241. I just went to my mother, with my mother to her ophthalmologist. My mother has bad macular degeneration. And every time she goes, she gets a fluorescein angiogram. The doctor doesn't even do it. He's not even in the room. Okay, I know he probably looks at the pictures. But it's a technician does the study. And he glances at the pictures, that's $241, and that's every time she goes. The liability crisis is a mess. Oh, one other thing I want to say about these codes. Look at the bottom left, the medical conferences and telephone calls. I mean, to me, that's adding insult to injury. This is what we do all the time. Medicare has a CPT code for it, but they assign no reimbursable monetary value if you perform these services. So and I'll talk about the liability crisis. I just read this on the AMDA website, that a physician was told by his malpractice carrier that his annual premium was going to go from $7,000 to $34,000 a year, and warned him that it would jump to $100,000 if he continued, not neurosurgery, but if he continued to see patients in nursing homes. So at the risk of boring you, I presented the demographic data on our aging society, the data that demonstrate that we are not producing geriatricians in sufficient numbers to care and advocate for these very vulnerable people. And I have mentioned a few reasons why I think physicians in training shun our specialty today. I did this because I have learned something else from the correspondence I have received as a result of my health affairs piece. And frankly, it's disturbed me greatly and even frightened me. I want to read the last part of What Are We Going to Do with Dad, the part in which I voice my fear that my father may fall at home and break his hip, and I fantasize what I might do. In fitful sleep, I dream that when the time comes, I go to my father's bedside, quietly fill a syringe with morphine and stroke his arm as I place the tourniquet. I tell him over and over again how much I love him and what a good father he has been to me, as I slip the needle into his antecubital vein. Then I say how much I will miss him, and goodbye, Dad, goodbye, as I push the contents into his bloodstream. In this dream, I tell my mother and my brother that he has gone peacefully in his sleep. I've not until now given voice to this dream because I know for certain that in the end I could never do this. Not to my poor demented father, not to anyone. I know there are some who would disagree with me, and perhaps this is one way our society will ultimately deal with its flood of elders in this age of limits. I will be, by then I hope, old and no longer on the front lines. When my time comes, before it comes, I will choose for myself. But for now, as long as I have the will and the strength to practice, I am a physician deeply steeped and rooted firmly in the art and tradition of healing, of comfort. To those of us in geriatrics who care for this vulnerable population, I believe the feelings I just expressed are nearly universal. For many of our fellow citizens and some of our colleagues, they are not. I want to close by reading a chapter of my book in progress, a narrative I described as a memoir manifesto. This chapter is titled, Stop Torturing Your Father. It is a beautiful early November day when I pull into my parents' driveway. San Antonio has had its first cold snap. The temperature just a few nights ago dropped to the upper 30s as the first norther of the season blew through town like a freight train. These fronts never last long here in South Texas, and today the high is 75 degrees and the cloudless sky is as blue as the iris of the newborn. There is a flock early for this time of year of cedar waxwings gorging themselves on paracantha berries. My father planted these bushes in front of his house years ago. I am now older than he was then, just to attract these winter visitors. The only real reminder that this is autumn is that the leaves of the Spanish oak on the front lawn of my parents' house are suddenly a brilliant red. A few have already fallen to the ground. All the other vegetation, the two pecan trees, the lawn of St. Augustine, is still green. At least for a time they will remain this way. It is a Wednesday afternoon. I have finished up with my patients a bit early, and since this is flu shot season, I have brought a preloaded syringe with me that I intend to give to my father. It was just last week that I picked up my mother on my way to work one morning. We'd arranged for my parents' home care aide to come early so that I could take my mother in for her regularly scheduled appointment with Dr. Galan, one of my younger associates. She had her checkup, got her flu shot, and hung out with the women in the business office with whom she had worked for over 25 years before her macular degeneration advanced to the point where she could no longer type or read. Faces to her are just a blur now, but she enjoys visiting with her former co-workers, and I love hearing her gab and laugh with them. My father's appointment with Dr. Galan is not for another couple of months, but I want him to have the protection of the flu vaccine, so I bring it today, intending to administer it myself, something I have done for the last few years, just to save my father the trouble of an extra trip into the doctor's office. In his weakened condition, with the progressive decline in his walking, the need for a walker and a wheelchair and more than one strong back becomes a logistical feat to get him out of the house. Giving his flu vaccine myself seems a beneficent act, something I am privileged to be able to do, something I wish were a readily available service for all my frail elder homebound patients. Once again, I realize how fortunate my family is. I am still sitting in my car on my parents' driveway. I am shaded by the Spanish oak, and a brisk breeze brings a shower of red leaves across the windshield. There was a letter on the seat beside me that I fished out of my mail pile just before I left the office. The envelope has no return name or address. It's postmarked from a city in Ohio where I know no one, and the letter itself is unsigned. I had scanned the first few lines in my office, stuffed it back in the envelope, and carried it out to my car, intending to read it later. I pick it up again now. It begins. Ray, what are we going to do with Dad? Dear Dr. Winakur, I was very disappointed in your article above, which appeared in the San Antonio Express News. How could you possibly torture your own father and prolong his dying like you are doing? What kind of fiend are you? This is as far as I got when I first opened this letter just 20 minutes ago, but now I force myself to continue. Your father's major problem is metacarditis. If he and his family, meaning you, had to pay for his dying directly, rather than palming it off onto working families with children via Medicare, your father would have died a natural death years ago with his CHF. I guarantee it. A sick feeling is washing over me. I sense that this is not just your average reactionary. CHF is a commonly used medical abbreviation for congestive heart failure. I keep reading despite my overriding desire to tear up the letter and toss it into the garbage can at the curb. Now I realize that the medical industrial complex uses demented old people as cash cows and ATM machines all the time, but to do that to your own father? Why? How terribly cruel you are. Don't you remember when we were all in residency and wanted to tattoo DNR onto our chests? There was a reason for that. We knew back then the care was futile. Well, now is the time to do that favor for your own father. And tattoo, do not call 911 onto his chest too while you're about it. My fear is confirmed. This person too cowardly to sign his or her name is a physician. Someone who took the same oath as I. What are we going to do with Dad? The answer is simple. We're going to let God be God. We're going to let nature take its course. If he dies, he dies. If he lives, he lives. No flu shots, no calling 911, no antibiotics, no trips to the hospital. They're better off dead. Death is inevitable for all of us. One can die quick, or one can die slowly, tortured by a son like you. I fold the letter back into its envelope and pick up the syringe loaded with my father's dose of flu vaccine that I have wrapped in aluminum foil. The vaccine costs $10 a dose from the manufacturer, which is exactly what Medicare reimburses us physicians on each dose we administer. Here is what is entailed. We must order it, pay for it, store it, sort it, draw it up into syringes which we supply for free, schedule and debrief each patient, get them to sign special forms, administer each shot, alcohol swab included, record each vaccination into each medical record, assume the responsibility for each untoward reaction, generate an electronic insurance claim to Medicare on each dose given, and wait months to get paid. There is only one reason for a group practice like mine to go through this each year with our geriatric patients, and that is because we believe it is the right thing to do, because we believe that yearly flu shots will in the aggregate relieve suffering. Geriatricians have always stood at the wrong orifice of the Medicare cash cow to which my so-called colleague referred. I get out of the car and head up the walk to my parents' front door. Two white-winged doves coo and then flush from the pecan tree. I let myself in. As usual, it is dark inside. My parents don't believe in sunlight. My mother worries it will fade her 40-year-old sofa, while at the same time she bemoans the fact that her plants always die. My father likes the curtains closed so no one can peer in at him. My mother is asleep in the recliner in front of the blaring television. Whenever I visit, my first move is always to find the remote and mute the TV. This wakes my mother. I kiss her on the forehead. Her silver hair is all poofed up and smells like shampoo, and I remember that this morning was her regular weekly visit to the beauty shop. My brother took her in, and my wife picked her up and took her out to lunch before bringing her back in time for the home care aide to leave. "Oh, you're here," she says. I move around the room, opening the curtains. "It's a gorgeous day," I say. "I stopped by to give Dad his flu shot." "Your father's asleep as usual," she says. "Well, looks to me like you're both taking a siesta," I say. "He's been keeping me up at night again with his wanderings and ravings," she says. "Are you remembering to give him his nighttime medicine?" I ask, knowing she was always trying to cut back on it. A good reflex on her part, but always to the detriment of her own rest. "I guess I'll have to start it up again," she says. "You know, it makes him more sleepy the next day." "Mom, we've been through this 100 times. I head back to my father's bedroom. He is asleep. The side rails of his hospital bed are down as they should be. "Dad," I say gently, then a bit louder. "Dad." I put my hand on his shoulder. He opens his eyes for a moment. He is frightened. He is trying to make sense of what he sees, who I am, where he is, who he is. "Dad, it's me, Jerry. How are you feeling today, Dad?" "Jerry, is that really you?" I see in his eyes that the fear is subsiding. "You don't come around much anymore, do you?" he says. "Dad, I come over here all the time. Why don't you let me help you up and into the living room? Mom is there. We'll visit a while." "Mom? Where is Mom? I thought she was dead." "No, Dad. Mom, your wife, my mother. Come, you'll see her in the living room. It's a beautiful day. Maybe you'd like to sit outside. There's a flock of cedar waxwings feasting on your pyracantha berries." "What?" he says. "Wax what?" "Waxwings, Dad. The bird, golden body, black face, crest." "I don't know what you're saying. I'm too tired. I don't feel so hot. Let me go back to sleep, will you now, please?" He's getting agitated, and I know not to push him further. "Okay, Dad. Okay. Go back to sleep. Just one quick thing. Let me give you your flu shot. It'll only take a second." "My what?" "You know, the flu shot. I give it to you every year so you won't get the flu or pneumonia. Look, I have it right here in this syringe ready to give it to you." "Do you know what you're doing with that?" "Dad, remember, I'm a doctor. Your son the doctor, remember?" "How long have you been a doctor?" "Over 30 years now, Dad." "I can't believe it. Really? Has it been 30 years?" he asks. "Time flies," I say. "What do you say, Dad? How about I give you this flu shot now?" "By all means," he says. 30 years. I don't believe it," he says. It only takes a few seconds. "How was that?" I ask. "I didn't feel a thing," he says. "Good. Why don't you let me help you into the living room, and you and Mom and I will have a visit." "Mom is here?" he asks. "Yes, Dad, she's in the living room." "Well, sure," he says. "I love to see Mom." I help him get himself together, find his glasses, balance him on the side of the bed, set his walker in front of him, give him a boost to his feet. "I'm weak as a kitten," he says. He pushes his walker, and they keep a hand on him from behind. God, I feel like an old man, he says. I notice that he is dragging his left leg a bit, and I wonder if perhaps he's had a stroke. I make a mental note to speak with Dr. Galan about this in the morning. Maybe he will agree that my father might benefit from some physical therapy visits to the house or some muscle strengthening exercises. There she is, he says. He has rounded the hall into the living room, and he catches sight of my mother in her chair, her silver hair radiating light from the window. My beautiful wife, he says, suddenly abandoning his walker and making a lunge for the corner of the couch next to her chair. Dad, what are you doing? You're going to fall. I want to sit down next to my beautiful wife, he says. He is short of breath from the 20 steps he has taken. Now I'm his wife again, my mother says to me. This morning I was his sister. What do you mean, my father asks? Of course you're my wife. Don't you think I know my own wife? And I love you. You know that I love you, don't you? Yeah, I know, my mother says. And she loves you too, Dad, I say. Of course she does, he says. We've been married a long time, haven't we, Mom? How long have we been married? 59 years, she says. He turns to me. Did you hear what she said? 59 years. That's a hell of a long time, you know, and I've loved her every minute, he says. Haven't you loved every minute of it, Mom? He asks her. Oh, yes, she says, every minute. What I tell you, he says to me. I do not answer. The TV is on, still muted, yet the news channel blares, even without the sound. Irritating bits of information crawl across the bottom of the screen like ants at a picnic. Today it's all about the scare over avian flu, the very real fear that a global pandemic will kill tens of millions, maybe hundreds of millions. Without an effective vaccine, my father will die, my mother. I think about my anonymous colleague and his letter. There's more. With enemies like you as his son, your father desperately needs a good friend like pneumonia to help him now in his time of need. We human beings all need to develop more nobility and inner strength so that our mothers won't call us with fear and panic when a crisis occurs, but with courage and bravery. We need more practice dying, going out with a bang and not a whimper. We need to face death unflinchingly, not whining and wheedling. I haven't died yet, so I don't know what I'll do. Suddenly I am livid over this creep, this colleague of mine. Such a sanctimonious, paternalistic son of a bitch, pontificating over a situation he knows nothing about. Where is his empathy, his humanity? He presumes to put himself in my place, or in my father or mother's place. He would deny flu shots to the oldest old. Why, I bet he's hoarding Tamiflu as I write this. Perhaps if he comes forward, he will be appointed Secretary of Health and Human Services. Washington can use an idea man like this. Bureaucratic foot-dragging on influenza vaccines, especially if we can fumble the ball on the truly pandemic strains, is a great way to decrease Medicare spending, not to mention a final solution for the Social Security mess. Avian flu, bring it on. I take the remote from my mother's lap and turn off the television. I sit back down in the chair and study my parents. My father is looking into my mother's face. I don't want to get into this, but I just can't help myself. Dad, I say, Dad, are you happy? He looks at me for a few seconds and back to my mother. Outside the window, the waxwings are gorging themselves, coming and going in throngs, diving into the clusters of red berries. Frances, am I happy? He asks her. My mother releases the lever on her lazy boy. Her body springs to attention. She wants to hear this conversation I am instigating. I can't answer that for you, she says. You have to answer for yourself. My father looks back at me. Dad, are you happy? I ask again. Why are you asking me? You should ask your mother. I'm asking you, Dad. Well, of course I'm happy. I love your mother. But you never go anywhere, Dad. You're more or less a prisoner in your own home. I like it here, he says. There's nowhere I want to go. Dad, you do so little now. You sleep most of the time. My mother says, Len, you know you're sleeping your life away. My father just sits. Maybe he is trying to remember. I don't know what is happening in his brain. He is searching all the empty corners for his forgotten life. His dead mother and brothers and sisters. His return from the war to the waiting bride who wrote him a letter every day for almost 5 years and sealed each envelope with a big lipstick-smudged kiss. His 2 boys snuggled up into his arms for a story at bedtime. His fishing trips out to the mouth of the South River of the Chesapeake Bay. His artist soul retrieved and lost again. He looks once more at his silver-haired wife. He is thinking. Perhaps he is even remembering. But even if he cannot remember, here he is today, with his wife beside him, no matter how complicated their life together has been. He truly loves her, and she is here, still by his side, frustrated and complaining at times, but still here when he needs her the most. Finally, he is ready to answer, and I am waiting. I know I sleep a lot, he says, but I have delicious dreams. What? My mother asked. What's he talking about? She is leaning forward in her chair, trying to get a clear look at her husband. It's okay, Mom, I say. It's fine. My parents search each other's faces. Outside the window, the waxwings tear into the paracantha berries. My father is suddenly aware of them. Look at all the birds, he says. I planted those bushes, you know. I remember, Dad, I say. Would you like to sit outside for a while and get a closer look at the birds? Sure, he says. Don't forget the binoculars, he says. My father, one of our country's oldest old, has delicious dreams. There are those who believe that the lives of people like him have no value. But I, his son, the geriatrician, do not need to hear anything more. Do I really understand what he means? No. But the day will come, and I am waiting, when I will taste these dreams for myself. Thank you. So I don't know if anybody has any questions. I mean, I'd be happy to answer some questions.
Thank you very much. It was very personal. Thank you for change.
Well, I hope I didn't bore you with the statistics business, but I guess it never hurts to hear it from more than once. Well, you're a very attentive audience, and I thank you for the opportunity of letting me come, and I hope we can get together again sometime. Thank you very much.
I have one comment, actually. You mentioned some of the reasons people are not going into geriatrics, and one wonders what one can do about such a trend. One of the reasons I think that people may not have the opportunity to go into geriatrics, even as we speak, is a decrease in federal funding for educational programs for health professionals going into geriatric medicine and related fields. When I was very young, I used to believe that science and medicine and so forth were not political, but I think everything is political and becoming increasingly so. Very recently, a bill which was put together through a joint House and Senate subcommittee to cut medical education funds through the HRSA and through the NIH, came out with a budget that zeroed out geriatrics education in this country. And of course some of our own programs here, and some of you have been the beneficiaries of these programs. There was in fact a hue and cry from the academic and I'm sure other community, at least the geriatric educators, using their private hats, I might add. These statements are not for the record, and they're not being made in a federal institution. But it turned out that the House, shortly thereafter, voted that bill down, which came as a total shock to most. But I do believe that the reason that happened is because of the efforts made by cognizant professionals in their private from a private standpoint arguments made to congressional representatives who were frankly, and who remain in fear of losing their jobs perhaps next year. Battle one was won in a long war, and it's not clear where those funds will go, but I think we want to remain aware that there are things we as private citizens can do to try to retain at least a vestige of federal support for educational programs that are going to meet the geriatric imperative. And it's, I think it's important for us to be aware of the larger scene so that we can play a role.
Well, I'd like to make a comment. I'll get back on my soapbox for a minute. When I was at this ASA convention, I was sitting there listening to this guy from Intel, Eric Dishman, who's a communications major. He doesn't have any background in healthcare or medicine or anything, talking about holding up his little computers and saying this is the future of geriatric care in America. These little computers are going to collect real-time data. And I realized that there weren't any doctors at this ASA meeting, and all these people there that want to sell stuff to our patients. I mean, they're there to sell services and stuff to our patients. I let them know that if we don't train any more geriatricians, who's going to be taking care of their patients and order all the stuff they want to sell? So I don't, I'm not a political person. I don't know about these things, but it seems to me that companies like Intel and companies that make beds and companies that run nursing homes ought to get together and say, we better start funding some geriatric fellowship programs so we can have some doctors that know how to take care of all these patients we're going to want in our facility, and we don't want to be getting sued every time we turn around, so we ought to have people that know what they're doing. And I don't know who makes that case, where that case gets made. I'll make it in this book if I ever finish it, but I can tell you that there is an untapped resource unless you know about public-private partnership programs in that regard. I mean, all these people, and there are pages and pages in that convention booklet of people that were there, companies, making stuff, selling it to our patients that have an interest, a vested interest in having good doctors care for their elderly, that didn't even know that there was a crisis in geriatric care. I mean, when I put that slide up at the ASA convention, people went, "Oh, really? There's going to be a deficit of 34,000 geriatricians? There's already a deficit of geriatricians?" They didn't have a clue. So we're not getting our message across to people like that.
That's why I think the reception that your article got was so important. I hope you'll continue to write such articles on an annual basis.
Well, we'll see. I'm putting this book together, and it's about a third complete, and there will be some soapbox moments in there, and who knows, maybe some chapters will get excerpted out of that and get a more wider audience, because frankly I don't know who would in their right mind would buy the book, but if they can read it for free, if they can read it for free in the Washington Post or online, they'll probably read it.
If you have a signing at the TWIC, we'll all be there. Thank you.
Thank you.
Yeah.